Good evening, everyone, and welcome to tonight's Men's Health webinar. It is Movember, so you may be rocking a mustache, a full beard, be clean shaven, but either way, it is a month for men's health and men's health awareness. Fortunately, we have Dr. Ryan Dornbier here. He is a fellowship trained urologist, he's a passionate educator, and he's going to talk to us about the signs, symptoms, and treatment options for erectile dysfunction. We encourage you to ask questions anytime during this presentation. While it won't exactly be interactive, Dr. Dornbier will answer those questions live at the end of his presentation. To submit your question, you're going to move your mouse or tap the screen of your mobile device. You're going to see a bar pop up in Zoom. On that bar, you're going to see several different options. One is chat. So you click or tap on that chat feature, type your question in, hit enter, and again, we'll get to those questions at the conclusion of the webinar. Now, without further delay, I'd like to introduce Dr. Ryan Dornbier.
Hi, everyone. Thanks for coming. Please do submit your questions. It's great for interaction at the end of the presentation, but thank you all tonight for coming to our webinar about erectile dysfunction. As Mike mentioned, we are in the midst of Movember. I am not rocking a mustache. I have to grow out the full beard first before I can shave it into a mustache. So later this month, we will definitely have that going. But for right now, let's jump into the topics a little bit. For anyone who has kind of likes to do their own research or needs some instructional locations, the website edcure.com is great. If you scan your phone now, you want to surf while I talk, or just write it down to check out later, please do go to that website because it does have some great videos. As Mike mentioned, I am a urologist at the Urology Center of Iowa. I have offices at both UCI and Clive, as well as at our Broadlawns Clinic in Des Moines. And then I also have a clinic in Pella. You can see my training there. I did do fellowship training in men's health and reconstructive surgery. But enough about me. We'll go on and talk about what you guys are all here to hear about, which is the erectile dysfunction. So erectile dysfunction is defined as the persistent inability to achieve or maintain an erection for satisfactory intercourse. The numbers are fairly well dated at this point, and I think most people would think that these are underestimations, but it's about 1 in 5 men age 20 and over would experience erectile dysfunction, and half of men over 40. As you get older, the prevalence increases to the point where most men, by the time you hit 70 or 80, are going to have erectile dysfunction in some way, shape, or form. The erectile process is a fairly complex physiologic situation. Basically, as you're stimulated, blood flows in, and that blood needs to be trapped inside to stiffen. So what happens is the erection ultimately compresses the veins so that the blood cannot leave the penis, and therefore enables an erection that is firm enough for sexual penetration. So basically, long and the short of it is blood comes in, blood's trapped in. So any partial disruption of that process is going to result in erectile dysfunction. So risk factors for erectile dysfunction include age, smoking, history of diabetes, high blood pressure, high lipid levels, depression, obesity, and a sedentary lifestyle. But really anything that disrupts from a conditional perspective that inflow and blood trapping process. So vascular erectile dysfunction tends to be related to blood flow into the penis, whereas diabetes is kind of a two-hit because you have some decreased compressibility of the veins, and therefore you get what's called venous leak erectile dysfunction, where you can't trap the blood in the penis. Medications have also been shown, neurologic conditions, pelvic trauma, and then decreasing testosterone levels have been shown to cause erectile dysfunction, but it's a little bit more decreased libido than erection issues. Along with those conditions are kind of more what we would consider organic erectile dysfunction, meaning causes that would be associated with other medical conditions, but there are psychogenic or psychological causes of erectile dysfunction, including anxiety and depression, that can limit your abilities. I often tell patients with psychogenic erectile dysfunction that you kind of exist in a state of anxiety or sympathetic overdrive, which is kind of your fight or flight nervous system. And being a fight or flight, the evolutionarily speaking, we were not designed to have an erection while trying to fight a bear. So those periods of anxiety or high alertedness can often be difficult to maintain an erection. So diabetes is one of the most common reasons that we see men with erectile dysfunction. Half of men with diabetes are going to develop issues with erections, and they tend to be less responsive to medications and other treatment options. And sometimes the erectile dysfunction can be the presenting symptom of diabetes. So, and anyone who's presenting to me with new onset erectile dysfunction, I often check your hemoglobin A1C to check your sugar levels. The reason that diabetes is such almost triple whammy when it comes to erectile dysfunction is there's decreased blood flow into the penis, which then doesn't allow for the rigidity, but also the decreased compressibility of the veins, which inhibit blood trapping inside the penis. But the third hit really comes down to the nervous system, because the lack of blood flow to the uh, nerve fibers can cause them to fire less quickly, which is why patients with diabetes develop neuropathy, which also happens to the penis. So even there's decreased sensation and ability to achieve erection with stimulation. Factors that increase ED in men with diabetes include older age, poor blood sugar control, longer time with diabetes, concomitant vascular disease, or use of diuretics, and then heart disease, which we'll talk about here now in terms of its effect on your erectile function. So erectile dysfunction and cardiovascular disease are closely linked, to the point where if a young man presents to me with a new onset erectile dysfunction that I think is related to an organic cause, I often encourage them to go seek a workup for cardiac issues, or I will send a referral to workup for cardiac issues, because erectile dysfunction can present before a heart attack by about 2 or 3 years. Increases your risk of heart-related events, whether it's a heart attack or a stroke. Oftentimes, if you have really severe heart disease, you're also going to have very severe erectile dysfunction. Mainly, this is related to coronary artery disease, because if you look at your arterial diameters, when you look at the larger blood vessels of the body, be it the femoral artery or the internal carotid, which supplies blood to the brain, and then you look at the major blood vessels to the heart, which are your main your anterior descending coronary arteries, and then the penile artery is even smaller than that. So if you start to develop plaques or occlusiveness of the penile artery, it means that your cardiac vessels probably aren't far behind. So things that you can do to reduce your risk of cardiovascular disease are eating well, trying to maintain that more Mediterranean diet with fresh fruits and vegetables, avoidance of red meat, exercising and physical activity on a regular basis, losing weight if you need to, stopping smoking or alcohol or other illicit drug use, and also taking steps to reduce stress-related concerns. Kind of continuing on that erectile dysfunction associated with other disorders, low testosterone can be associated with erectile dysfunction. The body does have certain degrees of natural decline in testosterone levels as we age. If you check the average testosterone levels of a 25-year-old versus the average testosterone levels of a 75-year-old, pretty much across the board, the 25-year-old is going to have a higher testosterone level. So age is an associated risk factor for low testosterone, obesity, diabetes. Sleep apnea is a big one that often goes unrecognized. Other chronic medical conditions, as well as HIV and AIDS. So what are the symptoms of low testosterone? Well, the biggest one, more so than erectile dysfunction, is decreased libido, just a decreased drive to engage in sexual activity. Often that's associated with some degree of fatigue. You just don't have the energy levels the lack of endurance, or most men I discuss this with complain about just the early afternoon tiredness. They just can't seem to focus and concentrate after lunch, and it only gets worse until they can fall asleep. Testosterone therapy, there's patches, injections, uh, pellets that you can inject underneath the skin, long-acting injections, short-acting injections. More recently, we've come out with oral testosterone options. And if it's a concern for you, please do stop by, because we have a lot of options to replace testosterone. So one of the biggest causes of erectile dysfunction that can be fairly abrupt is treatment with prostate cancer. Whether that is removal of the prostate or even radiation. Basically, with the removal of the prostate, you disrupt the nerve and blood supply to the penis, which can limit your ability to get an erection. Post-surgically, usually that is very abrupt and then recovers the further you get away from surgery. But even after surgery, 50% of men are going to have persistent erectile dysfunction. So basically, during prostate removal, prostate gland sits below the bladder. There are nerves that surround it that then innervate the blood vessels into the erectile body of the penis. When that prostate is removed, we tie the bladder and the urethra back together, but that disrupts those nerve fibers. Even with radiation, men who or excuse me, with surgery, like I said, about 50% of men, probably more, are going to have some degree of erectile dysfunction. And a lot of men will have that initial ED persist even a year after surgery. So other conditions, again, these are more, I guess, penis-centric when it comes to their association with erectile dysfunction, that being Peyronie's disease. This has gotten a lot of publicity recently in terms of just getting the word out there that this condition exists. If you've seen commercials about medications, then you probably noted those. But Peyronie's disease is a disorder in which scar tissue builds up in the penis and then ultimately results in a curvature of the penis in that direction. It's not cancer, it's a benign condition, but it can be very painful to start. And then if you do develop curvature, it can be disruptive to intercourse, but it can also essentially block those erectile bodies in the penis, which then can then lead to erectile dysfunction. The treatment for Peyronie's disease specifically, there are limited oral medications to treat Peyronie's disease. There are injectable medications into the scar tissue or traction devices. Surgery can often be an option, but if you do have any degree of erectile dysfunction and a penile curvature, then I often recommend a penile implant as the best option to treat that form of erectile dysfunction. What should men with ED and Peyronie's disease know about penile implant surgery? It's a great option for men who are struggling with both erections and curvature, that even when you do get an erection, it is curved, or if you struggle mightily to get an erection. I think this is one of those circumstances that has probably the most benefit, because it's kind of a 2-for-1. You get a erection that's going to work every time. And when I put it in, I'll straighten your curvature, and therefore you'll get a straight penis that you can use and not have any issues with sexual penetration. So those are all the conditions that are associated with erectile dysfunction. We talked about both organic causes as well as psychogenic causes, but the treatment options kind of funnel into a little bit more of a straight line path. So who can treat erectile dysfunction? See a lot of general practitioners offering patients oral medications. Urologists naturally kind of deal with a lot of erectile dysfunction, but then when it comes to a prosthetic urologist, kind of does see a lot of that kind of end stage erectile dysfunction, in which recovery is going to be limited. So what are your treatment options? I'm glad we've kind of finally pared this slide down to these 4 options. They used to have urethral injections, but we don't talk about those much anymore. But there are oral medications, vacuum devices, injections into the erectile body of the penis, or a penile implant. There are a lot of other options out there which are more restorative, but these are kind of the mainstays of erectile dysfunction treatment. It's always important to talk about lifestyle modifications. For men with psychogenic erectile dysfunction, it's important to control those anxieties and psychiatric disorders, but also important if it's a measure of performance anxiety related to sexual activity, to seek out a psychosexual counselor, which if we do refer you to those, it's very helpful. Also, lifestyle modification: stop smoking if you're a smoker, lose weight if you need to lose some weight, increase your physical activity, control your diet, drink less, all things that you've heard about probably nonstop for your adult life. So starting with medications in terms of active treatment, these are PDE5 inhibitors. They've been around since the early 90s when Viagra came out. They essentially stimulate the blood vessels to relax more aggressively to allow increased inflow into the penis. That process takes about 30 to 60 minutes to improve, or improve that blood flow. And you do still need sexual stimulation in order to achieve an erection. The biggest issues with these medications is the side effects, or loss of efficacy. I usually say about 60% of men are going to respond to PDE5 inhibitors. But a lot of patients will have bothersome side effects, either headache, facial flushing, upset stomach, heartburn, muscle aches and pains, congestion. Some guys complain of a hangover type effect. And there are some medications that you shouldn't take these with. The vacuum device is here for completeness sake. The really only time that I think it is a valuable option is for restoration of the length after prostate removal. So basically you put a hollow tube around the penis and you vacuum out the air, which then pulls blood into the penis. Then you then need to use a rubber band around the base of the penis in order to maintain blood inside the penis. But if you've ever put a rubber band around your finger, you know it turns black and blue and gets numb. The same thing happens to the penis, and therefore it can block ejaculation, cause bruising, discomfort, pain, numbness. Most guys I know will use it once and then put it in their closet, hoping never to see it again. Like I said, the only time I think it is helpful is if you have a patient who is after a prostate removal. We talk about penile rehabilitation. It can help maintain length so you don't lose length in the recovery period for your erectile length. Intracavernosal injections are kind of the mainstay of therapy after PDE5 inhibitors. Now you can jump to these right away, but if you, I say 90% of men are going to respond to intracavernosal injections. Basically, you take a medication out of the fridge, you fill it into a very small syringe with a small needle, and you inject it right into the side of the penis. It is a medication, usually a combination of 3 to 4 medications that work similarly to Viagra, but on a local level, and therefore increase blood flow to the penis. They work very well, usually in about 10 to 15 minutes, but a lot of patients will have to escalate dose over time, and over time will lose efficacy. You're also at risk of developing a priapism, which is a prolonged erection that becomes painful. Sometimes if you inject at the same site over and over again, you do develop scar tissue that can make it develop curvature. You can have hematomas or blood collections underneath the skin. The biggest issue with them is they are slightly inconvenient. You have to keep the medication in the fridge and away from bright lights. It can be a little bit costly. You got to fumble around with the needles and things like that before you want to engage in sexual activity. Last but not least is the penile implant. So the penile implant comes in multiple shapes and forms. What you see here in the bottom right corner is the 3-piece component inflatable penile prosthesis. Is it a device that is implanted into the penis that allows you to get an erection that lasts for as long as you want, and with more spontaneity, and designed to maintain through all sexual activity. The biggest issues it's going to get you an erection every time you want it. Like I said, for as long as you want it. But it is a surgical procedure in which the device has to be implanted. Um, Once the device is implanted, most men are very satisfied, but it is a mechanical device, so there are um, occasional issues with mechanical failure. And in rare instances, the device kind of pops through the skin and has to be removed. But patients tend to be very satisfied once they have recovered fully from the operation. So you can see the different options here. Um, these two, the AMS 700 and AMS 700 with the Tenaccio pump, are fairly similar. They have the pump portion that goes within the scrotum, the device portion that goes within the penis itself, and then a small reservoir that goes up underneath the muscles of the stomach. When you pump the device in the scrotum, it takes fluid from the reservoir into the erectile bodies, and that allows you to get an erection. Then you hit a button, and the erection goes away. The Tactra is a malleable device. It doesn't have any additional components, but it doesn't get quite as rigid and it doesn't get quite as soft as a inflatable device. So again, the AMS 700 penile implant has a protective coating that helps prevent infection. It is designed to mimic a natural erection, so it is not a natural erection anymore because your erectile bodies are replaced with inflatable tubing. Like I said, you pump the device within the scrotum, fluid flows from the reservoir into the tubing in the penis, which allows you to get an erection, and then you hit a button, it goes back down. Has more natural appearance and gets fully rigid for successful sexual penetration. I'm gonna play a quick video here. So you can see kind of the setup and the view coming in. There's a pump within the scrotum. When he pumps, the fluid goes from here up the tubing and into the device, which allows for the erection to be obtained. Once you're done using it, you reach over top the device and hit the button that deflates, and the fluid moves in the opposite direction, and you can see the penis goes back down to flaccid. We will on. Maybe. There we go. So what to expect? It is a surgery, so the surgery requires some recovery. I do my best to equate it to a knee replacement. Most patients are more familiar with people who have had those that have had penile implants, but you don't expect anyone to, undergo a knee replacement and to run a marathon the next day. There tends to be a little bit of recovery. It is an outpatient procedure, so you will go home the same day. I usually have you come back then in 2 to 3 weeks to check on the incision to make sure things are healing well. And at that time, we will activate the device. If things go well with activation, then I can allow you to start using the device at about 4 weeks after the implant. Despite it being activated and usable, it doesn't mean you're necessarily fully recovered. Sometimes there is still a little bit of residual inflammation or residual discomfort. That tends to go away, and by 3 to 6 months after the surgery, you are fully ready to go. You don't even know it exists. You're almost an expert at using it, and that's kind of when that period of patient satisfaction really starts to hit. I get a lot of questions about, is it covered by insurance? For the most part, yes. We can always screen your insurance coverage to see if you are eligible. Medicare pays for it fully, so most commercial payers kind of have followed suit. There might be an out-of-pocket expense if there are some exclusions on your policy, but don't let the possibility of non-insurance coverage stop you from at least seeking consultation, because we can always find out for you. What men say about their implant. Usually it's good things. This is kind of where that ED Cure website kind of comes back into play. There's a lot of videos about patient survivorship and satisfaction, also more about use and tools to teach you how to use the device, but also kind of show what life is like after surgery. So this is just statistics on what patient satisfaction and how it appears natural. It's reliable, durable. Mechanical failures tend to not happen for about 15 years after the device is implanted. Revisions happen for various reasons, but for the most part, revisions are few and far between. Risks. So the biggest one I talk to patients about is infection. That's where that inhibisone and protection from infection are helpful. But if an infection happens, the device does need to be removed, which can make it difficult to reinsert. But luckily, those risks are low. It's only about 1% risk of infection. Malfunction is another one. Like I said, it's about 50% at 15 years. Rarely do I see device migration or tissue exposure. Um, there used to be a problem with unintended inflation of the device with soreness, but those kind of have been sorted out with the newer generations of the pump. Um, Other things that you might have some lumps or bumps that are a little bit new. Sometimes you can feel the tubing. Sometimes a lot of men have more girth, but there's also a lot of patients have concerns about their length, and we talk about that in any sort of consultation in terms of expectations. Biggest thing to know is that it's a very common condition, like we said. 50% of men over the age of 40 are experiencing some degree of erectile dysfunction, so you are not alone. It's important to seek out or speak to your urologist about any concerns you might have. We're always there to help. So please call or schedule an appointment if you so desire, so we can talk about your treatment options. The safety information. We'll get to the question slide here eventually. There it is. All right. Are there any questions?
So I'm going to start with a pre-submitted question, if that's all right.
Sure.
So you had a diabetic patient um, who has erectile dysfunction
Mhm.
and notices that there's some inconsistency in the function. And I want to know, why is it that sometimes they're able to get an erection and other times, maybe for a couple weeks, it's seemingly impossible?
Yeah, it'd be that can be one of the frustrating parts about erectile dysfunction is just the lack of consistency surrounding your own individual results. Um, the ability of the vasculature to dilate to allow blood flow into the penis can be highly variable based on a lot of things that are happening physiologically. Your blood sugar control, your overall blood pressure, your overall degree of anxiety. I can't necessarily narrow it down to one thing, but it can be frustrating. So I understand that.
The question about pills. Is there a reason to prefer Viagra or Cialis?
There are a couple differences between each of them. Most of the time now we are using the generics, which are sildenafil and tadalafil. There's also other ones like Avanafil. They each have a different onset of action and time they last within the body. So Viagra tends to be a little bit faster acting, probably only need to take it about a half hour before you want to get an erection. Cialis tends to be a little bit longer, need to take it maybe 60 minutes before, but the Cialis is going to last in your bloodstream a lot longer. That's why there are daily dosage formulations of Cialis or tadalafil that can stay in your bloodstream for more like, I think it's 50 to 54 hours, whereas Viagra tends to be out of the bloodstream about 12 to 16 hours. On top of that, they have kind of different side effects. Viagra tends to, in my opinion, tends to be a little bit more intense from a side effect profile, especially when it comes to like the headaches and visual changes, whereas Cialis tends to be a little bit more related to muscle fatigue and aches and pains.
Thank you. Now, there's a question about male enhancement pills. And I think this can cover everything from T boosters to libido boosters to
Hmm.
specific ones for erectile dysfunction. Can you maybe talk about the risks, benefits, good, bad of those pills?
So I assume we're talking about the kind of marketed testosterone boosters, or even prostate pills, or those type of things. The biggest issue with those is they tend to be like herbal forms of testosterone boosting medications, which tend to, they're not regulated. And so, with a lack of regulation, we don't know what dosage you're getting. We don't know the true effects, because it's basically saying, like, here, drink some green tea, and that should improve your overall testosterone production, but that's never been studied. Um, so typically they don't hurt other than financial costs, but they've also not been proven. Now there are some uh, energy producing compounds and sterol medications that might boost your testosterone a little bit, but again, not studied.
So, a question about erections lasting longer than 4 hours. If someone
Mm-hmm.
goes to bed after they've had sex and still has an
Mm-hmm.
erection, um, is that dangerous? And how will they know if it lasts longer than an acceptable period of time?
The 4 hours is kind of a good guideline, not so much a diagnosis of priapism. Most men who develop a priapism, you're going to feel it. It's not going to be something where you're like, I'm going to go to bed and then not wake up if I have an erection that lasts too long. Erection or priapisms are painful. They're very painful, to the point where you're going to wake up if you are in discomfort from an erection that lasts too long. They're pretty rare outside of circumstances where you're using medications to get erections. Uh, they don't tend to happen with Viagra and Cialis. They tend to be only for men who are on injectable therapies. There are some other blood-related conditions, whether it's um, a blood dyscrasia, sickle cell disease, or sickle cell trait that are associated with increased risk of priapism. There's also some cancers that are associated with priapism, but for the most part, if you just have a regular erection that you used and had sex before bed, you're not going to develop priapism.
So just to reiterate, if there's discomfort or something doesn't feel normal, that might
Yeah,
be a warning sign not to pass out.
usually by 4 hours, the erection has become painful. That's why it's a good guideline. But you can develop a priapism an hour after giving yourself an injection. You can develop a priapism, 6 hours. But if it's something that's lasted a long time and starts to become painful, really the pain is really where it becomes problematic.
Is there any concerns of using Viagra with terazocin?
That's one of those medications that can have a associated decrease in blood pressure. Be cautious. It's not necessarily a complete contraindication, but don't take them at the same time.
So it looks like we don't have any more questions this time. I'm going to put a last call in there for questions. And in the meantime, Dr. Dornbier, if somebody wants to get a hold of you, see you, what's the best way to do that?
Oh, call our office, and I should have that number memorized a little bit better. I will look it up on my phone right now. It's 515 3, or excuse me, 515-400-3550. That will allow you to, call to schedule an appointment. Or if you want to visit our website, you can book online. That is www.iowaeuro.com. This video should be up on there, along with other videos of webinars that I've done previously, and other videos and links to our men's health center and stuff like that.
There's a question that came in about age.
Mhm.
So they're 80. Is that a problem? Is there any age at which you stop treating erectile dysfunction?
Nope. It's really based on your overall health. If you're 80 and you have really severe vascular disease and diabetes and are on a bunch of different medications, you might not be a great surgical candidate for a penile prosthesis, but there are other options for you. So no age barrier, more of a health barrier.
Now, a question about sensation. So, did sildenafil or any other of the pills cause a loss of sensation or feeling? Penis feels less sensitive to stimulation after penetration. Um,
Not that I'm aware, um, but maybe. Not that anything that's ever been reported. Usually it's increased sensitivity, so we have to find ways to keep guys from ejaculating too soon.
why does eating after taking the medication reduce the efficacy?
The medication is absorbed via fat channels. So most people are going to be, taking the medication and like maybe going out to eat for a romantic night or something like that. If you have a really fatty meal, the medication and the fats chelate, and then it doesn't get absorbed the same way. So the lack of absorption related to the interaction with fatty foods.
Do beta blockers have an impact on erectile function?
They do. They can cause some degrees of erectile dysfunction. Usually it's for more generalized beta blockers like a metoprolol. The more the newer generation ones like carvedilol and labetalol tend to not be as much, but still can. It's one of the first things I look at when you come in and you're like, hey, I got erectile dysfunction after I started this new medication. Luckily, we don't use a whole lot of beta blockers for general hypertension now. Usually it's guys who are more on it for AFib, so we don't see as many men coming in that can't get off of their beta blocker.
It looks like there's no further questions at this time.
All right,
Dr.
perfect. Thanks everybody for coming.
I want to thank you, Dr. Dornbier, for all the information you shared and for answering all those questions. I want to thank everyone who came out supporting Movember, took time to learn and advance their men's health. So, Dr. Dornbier, last minute here, any final words for everyone in attendance tonight?
I think that last slide, the second to last slide, I'm not sure which one it was, but you're not alone. I think there's a certain degree of taboo around erectile function and sexuality, especially here in Iowa. Um, so if you are experiencing something, please do reach out. There's not going to be any judgment. Um, get information, come in for a consultation. It's nothing to be embarrassed or ashamed about, because if you're dealing with it, I'm sure the person next to you is dealing with it too.
And thank you, everyone, for attending. And thank you, Dr. Dornbier. This concludes our webinar. Good night. Short intro, got no patient champion. Um, anything you want me to throw out there that's distinct from what we normally do?
No, let me just close out of all my things, so just in case something happens.